There we go. Hi, everyone. I'd like to welcome you to one of our SGE, Society of Government Economists, policy seminars. Today, we have a seminar on women and infant health inequality, U.S. and global perspectives. My name is Christina Miller, and I am the president of the Society of Government Economists. I'd like to welcome you all here today. For more information on SGE and membership, I have included our website below on the slide, and you could also follow us on, well, I guess it's X. I'm sorry, I didn't update this bottom of this slide, but we are at SGE_econ. So let me go to the next slide. SGE's mission is to support the professional development of government economists and economists interested in the economics of public policy. In terms of our virtual seminars, which we're also terming policy seminars, we have one that we're in the works on organizing. It will be in June, probably around the same time, sort of lunchtime seminar that will be focusing on sanctions. So please stay tuned. We will be sending out emails on that, and it will also be on our website. And then the next thing I would like to talk about is our SGE at ASSA sessions. So currently we're putting out a call for people who might be interested in acting as a discussant for one of our, papers in one of our 7 sessions that we're in the process of organizing. But the ASSA conference will be January 3rd through the 5th in San Francisco. So if you are interested in being a discussant at ASSA in one of our sessions, please email me at president@sge-econ.org with your name, your agency, and potential discussion topics that you feel like you can discuss. And also, please really put some thought into whether you might have a high probability of attending in person. I know that some agencies may have some struggles with sending people to ASSA, so we're looking for people who have a high probability of attending in person that could act as a discussant. So please visit our website for more details on our conference. And with that, I'm going to stop sharing, and I'm going to turn it over to Mel Sachs, who will introduce our speakers.
Okay, thank you, Christina. The Society of Government Economists brings together economists at all levels of government and from the private sector for discussion of economic issues involved in public policies and programs. My name is Melvin Sachs, and along with Christina, I am co-host of the Society of Government Economists Seminar Committee. SGE welcomes new members, and I hope you will consider joining. The website is sge-econ.org, and you can become a member by going online to the site. Today, we present a webinar on disparities in women and infant health inequality, which has been a long-standing issue in the U.S. and globally. Despite advances in healthcare, disparities in women and infant birth, morbidity, and mortality. I'd like to introduce one of our 2 panelists. Dr. Maya Rosen-Slata is an associate professor of health policy at Stanford University School of Medicine. Rosen-Slata's research focuses on issues in maternity, child and family well-being, health disparities, and public policies and other factors affecting disadvantaged populations in the United States and other developed countries. She received a PhD in economics from Columbia University and a BA in economics and statistics from the University of California at Berkeley. Dr. Rosine Slaughter, welcome.
Thank you. Thank you so much for having me. It's a pleasure to be here and get connected with this group. Let me go ahead and share my screen. And hopefully that works okay. Okay, let's see. Let me just go to full screen. Okay, is that looking okay?
Yep.
Awesome. Okay, great. So I'm here to tell you about some joint research that I've been working on with a fantastic team of collaborators that's attempting to understand sort of the nature of disparities in infant maternal health within the US, specifically in the state of California. So I'll be sharing some work from that project that we have done. And this is an ongoing series of projects that we're using with these data. I'll say, being here at the Society of Government Economists meeting, I am extremely thankful to government economists, and in particular, those at the Census Bureau. I think there's at least a few of you here because without them, this work would not be possible. So this is joint with Kate Kennedy Moulton, who's a PhD student at Columbia, Sarah Miller at Michigan, Petra Pearson here at Stanford, Laura Wary at NYU, and Gloria Aldana from the Census. And so because I'm using administrative data and census data, I'm giving you the disclaimer here that everything we have done has been reviewed for disclosure. So just to motivate this topic within the context of the United States, for those of you that are not as familiar with infant maternal health and kind of our comparisons between the US and global rates. So despite being one of the wealthiest countries in the world, America does pretty poorly when it comes to infant and maternal health. So in case of infant health, one statistic is that the US infant mortality rate is 33rd out of the 35 countries in the OECD. And really much of this poor performance is driven by the fact that we have a much greater amount of inequality in infant health in the US. So that means that if you look at, for example, children born to college-educated and married white mothers, their infant mortality rates are fairly comparable to those in, say, Europe and Canada, but we just have a much longer sort of left tail of the distribution where the rates for these outcomes for less advantaged families are much higher. And more generally across a broad range of disciplines, infant health disparities across racial and ethnic lines, as well as by sort of course educational groups, so college educated versus not, are very well documented. But we know much less about the relationship between parental income and infant health, nor on the intersectionality between income and race ethnicity. And I think this is a gap in the literature for a number of reasons. So one is that sort of education is a fairly coarse proxy for economic well-being. A lot of different income levels are represented in sort of these big educational groups. Moreover, the relationship between education and income varies quite a bit by race ethnicity. And we don't know, for example, to what extent that the racial disparities that are existing, so for example, Black infant mortality rates are almost double that of white infant mortality rates. To what extent are those gaps explained by differences in economic status across those two racial gaps, or to what extent do those racial gaps exist even within economic groups? When it comes to maternal health, we're an even worse outlier. So the most recent data from 2021 says that the US maternal mortality rate was 32.9 deaths per 100,000 births. That's triple that, more than triple that, of other peer countries, Canada, France, Sweden. And the racial disparities in maternal health are even bigger than they are in infant health. So non-Hispanic Black mothers experience mortality rates that are more than 3 times that of white mothers. The US is also an outlier in that it's practically the only country in the world that has actually witnessed an increase in the maternal mortality rate over the last few decades. Most other places around the globe have witnessed a decline in this outcome, and we've had an additional uptick through the pandemic in the recent years. But again, less is known about how economic circumstances drive or interact with these patterns. So why not? Why don't we know more about this, fairly sort of critical relationship between income and health? Well, really, it's a data constraint. So our standard measures of infant maternal health come from vital statistics, birth and death records data. And these data are fantastic in that they track these outcomes at the population level and collect information on race, ethnicity, and education. But however, these data have no information on income. So studies that have tried to say something about the relationship between income and these outcomes have had to rely on relatively aggregate measures of economic well-being. So for example, the county poverty rate. The limited research that has tried to use individual level income measures has relied on survey data. So I list one example here, but with survey data, you have the fact that there's relatively small sample sizes, which make it difficult to characterize how infant health varies throughout the full distribution of income or to look at the intersection between race and income. Moreover, self-reported income data is prone to measurement error. And then a final data issue is that there's been a lot of discussion about in recent years is that our measurement of maternal mortality is actually not perfect. It's based on something called the pregnancy checkbox on the death certificate. And the use of this checkbox has varied both over time and across locations, and making it quite prone to measurement error. So what do we do in this project? Well, we bring together a number of different administrative and survey data sets to try to understand how infant maternal health varies with family income. Specifically, we focus on the state of California. We have data on the universe of all infants born in the state for about a decade of time. And we merge these birth records data to tax data from the IRS, as well as some additional earnings data from the Longitudinal Employer Household Dynamics database, the LEHD, as well as several census data sets to essentially give us a near universal linkage of infants and mothers to family income in the 2 years before their birth. And then moreover, for a subset of those years, we also have a linkage to hospital and death records for the infants and the mothers. And we use these data to do three things. We're going to examine how infant maternal health varies across the income distribution. We're going to look at the intersection between income and race ethnicity. And then finally, we're going to benchmark what we find for the state of California to what we see in Sweden. Why do we do this in Sweden? For a couple of reasons. So one is that because Sweden has fantastic population level data, so this, just as a side note, putting together this data linkage took us at least 5 years and probably took off, a few months of our life expectancy in doing so. And this type of data is readily available in a few other countries, namely the Scandinavian countries. And so Sweden is one of those places where essentially this has been possible to do. And so because of that, a lot of the research that looks at disparities in infant health and links early life health to later outcomes has been set in Scandinavian countries like Sweden. So understanding how patterns in Sweden compare to patterns in the United States is important for sort of assessing the generalizability of what has been learned from the Scandinavian setting to other settings. Moreover, looking at sort of differences and so the patterns of inequality across the two places can be informative. So Sweden is a country that's known broadly for low income inequality, a wide social safety net, lots of family supports, a long parental leave program, access to subsidized childcare, and a number of other supports for families with young kids. And so one might suppose that for families towards the bottom of the income distribution, those that reside in Sweden fare better than those who reside in California or in the United States, where we don't have such a robust social safety net. But there's a question mark of what happens at the top of the income distribution. One might think that in a place like California and in America more generally, we're the hub for innovation. We have some of the best healthcare technologies, including in neonatal and maternal healthcare. And so some have argued that sort of to get the best healthcare, well, you have to pay a lot. you have to be in America. And so you might, given that, you might think, well, families at the very top of the income distribution in a state like California, the wealthiest families in California must do the best, right, in terms of these outcomes. And so we'll be able to shed some light, comparing kind of the top of the income distribution in California as compared to families in Sweden. Okay, so just a little bit more detail. I'll try to go through this pretty quickly to not bore you with all the details, but just to give you a sense of sort of the data that we're using. So the birth certificates data from California, the restricted version, has detailed information on health at birth, so all the standard birth outcomes that we can measure. We have the restricted version that has information on the identities of both the mother and the father. And for everything that we do, we're going to look at first-time births. And then finally, in a small number of cases, maternal or paternal identity information is missing, more commonly paternal identity than maternal. And so whenever we can, we're going to supplement with additional data sets that we have through the census to be able to try to fill in parental linkages. So how does this all work? So this, for those of you who are affiliated with the census, this is obviously not new to you, but just so everybody knows how this works. So the census assigns an anonymized identifier called the protected identification key, or the PIC, to individual records. And that's actually, the PIC is what they use to link across a lot of different data sets within the census. So we essentially brought in the birth records data, had them picked. So they ran them through the algorithm to assign them a PIC. And then in our case, we have full names, dates of birth, addresses that allow for this algorithm to work. And it's pretty good. So we're able to assign a PIC to, over 99% of the birth records. So that's for the children. The mothers are identified about 97% of all births, and the fathers are identified for just under 90% of all births. So our linkage rates are quite high. In terms of income, what do we actually measure? So we have both the W-2 earnings as reported by employers, as well as tax filings for the IRS. And so we essentially try to construct the AGI, the adjusted gross income, for as many households as we can, following prior work. And in a few cases where we can't find families in the tax data, we can find them in quarterly earnings data, which comes through the UI system. And so we fill those in through that. So just to give you a little bit more detail on exactly what our income is measuring. So if parents file jointly, we just calculate their AGI, net of transfers. If parents file separately, we sum the two incomes across the two parents. If filings are not available, we use the W-2 earnings. And then if none of that works, we try the LEHD. Then we take the average of the family income in the 2 years prior to the birth year. And if it's missing in one of the 2 years, then we just use the missing year. And then after doing all this, for some cases, we still can't identify the father, and then we just rely on the mother's income. In terms of some of our key outcomes, so the mortality data comes from two sources. So specifically, the Social Security Administration has what's called a numinant file, which contains information on Social Security number holders for the United States. And that data set has information on dates of death, exact dates of death. However, because the population that it's drawn from is Social Security card holders, and it actually is not good for measuring infant mortality, where unfortunately a lot of that mortality happens before the child has had a Social Security number assigned. So we don't rely on the numinant to measure infant mortality. Instead, we use sort of the standard infant mortality data from the Department of Healthcare Access and Information, but unfortunately that data linked to everything else is only available for a subset of our cohorts. So that's a limitation, but we can look at both neonatal death and post-neonatal death. Maternal mortality, though, the numinant is great at measuring because it tracks adult mortality rates very well. So we then bypass sort of all of the issues that I mentioned earlier with the pregnancy checkbox, because we can just basically link the births data and find whether the mother dies within a year following childbirth. So we bypass all the issues with pregnancy status checkbox. A limitation, though, is we don't observe cause of death. So we're essentially just looking at any death that occurs within a year post-childbirth. It does not necessarily mean that this is a death due to causes related to childbirth. We don't have that information, but a large share of them are going to. And then finally, we construct what's called a measure of morbidity for mothers. It's called severe maternal morbidity, or SMM. This is a standard measure that's defined by the CDC, and it's constructed using 21 hospital diagnosis and procedure codes that's essentially designed to capture complications of labor and delivery. Okay. So I'm going to be showing you pictures. There's no equations and really no regressions in this paper. It's really just visual and really just memes. And so I'm going to be showing you pictures that look like this. So let me just pause here to explain how these graphs are constructed. So on the x-axis, I'm going to draw your attention to the middle picture here. On the x-axis, we have income ventile bins. So this is 5% bins of the income distribution. And we're just showing the raw means in each income bin in the different outcomes that are presented here. So this is preterm birth rate. So that's birth at less than 37 weeks gestation. And it's calculated in terms of per 100,000 births. So what do we see? We see what's we call a J-shaped pattern. Okay. So as we start at the bottom of the income distribution, we see what we might argue is an expected relationship between an adverse health outcome and income. That is, the rates of this adverse health outcome are declining as we move higher in the income distribution. But when we get to about the middle of the income distribution, around the 12th ventile, the pattern sharply changes and reverses, right? So now we see that the rate of preterm birth is actually increasing. It increases so high such that in the top, 2 income ventiles, the rates of preterm birth are actually higher than they are for the lowest income families. Interestingly, we see a similar pattern for low birth rate. Okay, so this is completely different than what we typically see for associations between health and income. Typically, we see health as monotonically improving as we increase income. Here, we're actually finding that the rates of this adverse outcome, both in terms of preterm birth and low birth weight, which is less than 2,500 grams, are the highest for the highest income families, and that difference is statistically significant. However, when we look at infant mortality, which is arguably the worst and most extreme measure of infant health, we actually do not see this relationship. Instead, we see a classic downward sloping relationship, such as that the rate of infant mortality at the very top of the income distribution is much lower than the rate of infant mortality at the bottom of the income distribution, and that difference is about twofold. And we see this relationship hold both for neonatal mortality, that's within 28 days of life, and post-neonatal mortality, that's between 28 days and 1 year. And the thing that's quite striking here is that the families with incomes at the very top of the distribution we just saw give birth to some of the highest risk infants in terms of clinical indicators like preterm birth and low birth weight. And yet, despite that, they're actually the least likely to die. And again, that difference in infant mortality rates is about twofold between the top and the bottom of the income distribution. When we look at maternal health, we see qualitatively similar patterns. That is, for morbidity, so severe maternal morbidity or complications of pregnancy and delivery, we see this U-shaped pattern where the rates of this outcome at the top of the income distribution are actually similar to those at the very bottom of the income distribution. But when we look at maternal mortality, we see the downward sloping pattern where the rate of maternal mortality at the top of the income distribution is 3 times lower than it is at the very bottom of the income distribution, a threefold difference. Okay. So what's going on here? And so basically, when we look and try to explain these patterns, 2 key things matter. Women at the top of the income distribution tend to be older, and they're much, much more likely to use assisted reproductive technology. In fact, the difference in the rate of the use of assisted reproductive technology is 22 times higher at the top of the income distribution than the bottom of the income distribution. And births that are delivered through the help of assisted reproductive technology, so this is IVF and other types of fertility treatments, are substantially more likely to be non-singleton. So that is twins or triplets. Twins and triplets are clinically much more higher risk at being preterm or low birth weight. And so essentially what you then see is that the rates of low birth weight and preterm birth are disproportionately the highest for the highest income groups because of these underlying factors. But yet, what's I think important to keep in mind here is that these twins and triplets are clinically at a higher risk of mortality than singleton infants, and holding all else equal. And now, despite that fact, we actually see sort of the lowest rates of mortality at the very top of the income distribution. So not only are these pregnancies kind of the highest risk pregnancies that we could observe, they're also arguably the most protected and the most resourced, such that sort of those resources outweigh the risks due to the complicated delivery. Okay. That being said, this is not the only story. So this is not just a story about twins versus singletons. We essentially see the same pattern in terms of infant maternal mortality rates when we look at just singleton births. Okay. Now let's look at the intersection between race, ethnicity, and income. So here what I'm doing is I'm just plotting the same raw needs by income ventile, but I'm doing it separately by racial ethnic group. So you have mothers who are non-Hispanic Black in these diamonds here with the dashed line. Mothers who are non-Hispanic White are with the triangles here at the bottom, and then you have the other groups denoted here in the middle. So what do we see? So first of all, that J-shaped pattern, this is low birth weight, so that's less than 2,500 grams. That J-shaped pattern that I was showing you earlier is much more muted. Why is that? Because we had to extend the y-axis so much so that we could fit all of the different racial groups. So that means that the disparities by race ethnicity essentially swamp any differences by income. And what's quite remarkable here, and sort of, I think, really striking and important, is that the differences across racial groups do not get smaller as income rises, such that the rates of adverse outcomes for children born to non-Hispanic Black mothers are substantially worse and higher than they are for the lowest income non-Hispanic White mothers. So we see this for low birth weight. We see a similar pattern for preterm births. When we look at infant mortality rates, thankfully this outcome is more rare. So the patterns are a little bit noisier. Here we again see sort of the rates are disproportionately higher for children of non-Hispanic Black mothers. They're also disproportionately higher for this non-Hispanic other group, which is sort of a mix of a few different groups. But we think the main subgroup that's driving that is children born to American Indian, Alaska Native mothers that are also known to be disproportionately highest risk. And severe maternal morbidity, sort of the difference is even more striking. So for Black mothers, we're just seeing this really heightened rate of this outcome across the income distribution with no indication of convergence at the top of the income distribution. And same story for maternal mortality. So, the statistic that I cited earlier, Black women have a 3 times higher rate of maternal mortality as compared to their white counterparts. That exists even at the very top of the income distribution. So you may have heard stories, for example, of famous women like Serena Williams experiencing, difficult pregnancies and deliveries. And one response to that is like, well, that's anecdotes. That's a celebrity that gets profiled in the New York Times. Our data suggests that that's not an anecdote, that this is sort of a pervasive pattern that we're seeing at the population level. Okay, so this is just summing up what I just shared and putting some statistics there. The differences really are quite dramatic, right? So for example, 13.8% of children born to Black mothers in the top ventile of the income distribution are born preterm as compared to 9.4% of children in the bottom ventile for white mothers. And I should note that those income bins are the same throughout the population. So we're not like doing different scales by racial group. So we're essentially comparing the top 5% of Californians, but across different racial groups. Finally, let me tell you briefly about the comparison with Sweden. As I said, we can do the same thing in Sweden. One small limitation is we can't look at SMM in Sweden because we're lacking the relevant detail in ICD codes.
This is Rachel Sullivan.
I'm so sorry.
Maybe I have a question. Maybe I have stereotypes about the top 5% of Californians, but like, how many of those are surrogate babies to like bought by tech founders or whatever?
Okay, so I don't have information on surrogacy. What I can tell you is everybody that we're measuring is recorded in the birth records data at California, and the parents are listed as the parents on the birth record. So I think a fairly small share of that group would be what you're indicating, but I don't have the data to be able to say that precisely. Is that okay? So California versus Sweden. So we do the same thing in California as we do in Sweden. The income ventiles here are done the country specific. We can do them the same. It doesn't really matter. Here's the bottom line. The rates of adverse outcomes in Sweden are substantially lower than they are in California at all points in the income distribution, including at the very top. Okay, so these lines, the black and gray lines, like never cross at any point in the income distribution. So that's the case for these birth outcomes. For infant mortality, same story, right? So despite the fact that, in California, we might think we have the best neonatal technologies, the access to the best resources, the best hospitals. And so if anyone benefits from that, we would think it might be the top 5% of California's, the surrogacy tech families point notwithstanding. But nevertheless, right, these families, in terms of these really extreme adverse outcomes, fare worse than families throughout the income distribution in the country of Sweden. Maternal mortality, thankfully, a more rare outcome. So the patterns here are a bit noisy. That being said, at most points of the income distribution, it appears that California has higher rates. So let me just conclude with a few sort of lessons that we have taken away from this, and I'm curious to hear any questions and comments that the group has here. So as I've been saying, so one way to sort of think about healthcare comparisons between the United States and other high-income countries, everybody agrees the U.S. has a more unequal system and limitations on access to healthcare, especially at the bottom of the income distribution because of a variety of factors. But also everybody agrees that sort of one trade-off that we make is, yes, we have a more unequal system, but we have some of the best, healthcare in the world, right? Or so it's argued. So one way of making that case is that the World Index of Healthcare Innovation ranks the United States first in the world for new healthcare technologies. And this is particularly relevant to the case of neonatal and maternal health. I mean, just to put things in perspective, there have been important improvements in survival of infants over the last few decades, largely due to the fact that we've innovated substantially in this space. So there's a range of new technologies that are common practice these days that have first appeared in the United States that have made it possible such that infants born, at even very low gestation ages are able to survive and thrive. And perhaps that explains one of our key findings, which is that children at the top of the income distribution are born with the most health needs in terms of clinical indicators like preterm and low birth weight, and yet they experience the lowest rates of infant mortality. But it appears that the benefits from these world-class hospital technologies do not, so to speak, trickle down to all Californians. Despite being born healthier, infants in the lowest income households experience a mortality rate that's roughly double that of those in the highest income households. The maternal mortality rate difference is triple that. Okay. And again, despite the fact of, that we have these technologies and so on, no Californian at any point of the income distribution appears to be doing better than their Swedish counterparts. And, in supplementary analyses that I didn't show you here, we tried to look for sort of the plausibly most disadvantaged group in Sweden, which is sort of foreign-born mothers. Sweden is a big home to a lot of refugees from around the world. So if you look at foreign-born mothers who give birth in Sweden, they have better health outcomes throughout most of the income distribution as compared to even the highest income Californians. And then remember, we're doing this in California. So, in terms of if we're sort of trying to say something about the entire United States, if anything, California, we'd expect to do better than many other states. We have the 7th lowest infant mortality rate across the country. We also have a lot of leaders in maternal infant health happening here in the state. So a number of different programs targeting perinatal care, racial disparities, maternal care, and so on. We're also, in terms of social safety nets, doing pretty well as compared to many other states in the country. We're one of the few states that has paid family leave. We have more generous Medicaid benefits than most other states. And yet we're still seeing these patterns. And then finally, and I think really importantly, we find that differences by race at all parts of the income distribution are far larger than differences within race by income. And there's no evidence of convergence of racial disparities as incomes rise. So one implication of this is that targeting interventions based on income or socioeconomic status alone is unlikely to be sufficient to close racial disparities in infant and maternal health. We think that there's a number of reasons why Black infants and mothers experience these heightened rates of adverse outcomes throughout the income distribution. I've listed a few here: disproportionate supply side barriers within the healthcare system, sort of racial bias, for example, in the Medicaid payment algorithm, discrimination and systemic racism within the healthcare system, bias among providers, and a number of other sort of barriers. Moreover, the advantageous health outcomes in Sweden may emphasize the importance of equitable access to healthcare throughout the life cycle. So not just focusing on the pregnancy and childbirth period, but sort of thinking about how people are coming into the stage of pregnancy and what are the health outcomes that the healthcare and health outcomes that they're experiencing as they approach pregnancy, and how that impacts these downstream outcomes. And then finally, in terms of thinking about policy implications, sort of looking to other places that have done well on these dimensions, and how the policies that they bring, especially to the postpartum environment, that affect social and economic aspects of this environment, and not just the healthcare aspect. So things like paid family leave, things like nurse home visiting programs. So that's all I have, and I'm happy to. I don't know if we want. Are we just going on to the next presentation next?
We'll hold questions until the end, and if you have questions right now, you can put it in the chat or anytime, and then we can have a discussion at the end. Mel, you're still on mute.
Okay.
There you go.
Thank you, Maya. Got it. Dr. Anukriti is a senior economist in the Development Research Group of the World Bank. Dr. Anukriti's research examines the underlying causes of gender inequalities in developing societies and explores mechanisms that can bring about gender equality. Her research and advisory work at World Bank span a diverse set of countries, including India, Indonesia, Bangladesh, and Zambia, and Iraq. Also Lebanon, Jordan, and El Salvador. She received a PhD in economics from Columbia University in 2013. Okay. Thank you. Dr. Anukriti, pleased to hear from you.
Thanks, Mel. Thank you so much for inviting me. So we are going to now move to a different part of the world, and I'll take you to India and talk a little bit about gender inequality. So, we all know that there's been a substantial amount of economic development globally, including in India. But despite that, and you might expect that a lot of gender inequality may stem from underdevelopment or, lack of resources, which, make parents invest, let's say, less in their daughters relative to sons. But what we observe is that despite substantial economic development, gender inequality continues to persist in multiple domains. And today what I will do is sort of summarize several of my papers that focus on one particular dimension of gender inequality. So given that today we are talking about maternal and infant health, I'm going to focus on what is known as a male biased sex ratio at birth. So sex ratio at birth simply means the ratio of boys to girls that are born. And in countries like India, that sex ratio is substantially biased towards boys. So naturally, if you look at any population, for every 100 girls, there are typically 105 boys born. So there are more male births typically than female births, and that's because boys have a higher relative mortality rate in early childhood. So in order to sort of make it balanced, as they become a little bit older, naturally you expect that there will be more boys that are born than girls. But if you look at countries like India and China and several other countries, this sex ratio is much larger than 1.05. So in India, for instance, in 2017 to 19, the ratio was 1.110. Now, this may look small, but if you actually convert this into the total number of female and male births, this is a huge imbalance. And there are certain regions within India, especially, for instance, the North Indian states, where the ratio is even larger. So the state of Haryana, which I'm going to talk about in a little bit, the ratio tends to be 1.20. So this is comparable to what we have observed in China at various points during the one-child policy. And so people can use this to calculate how many girls are missing at birth, in the sense that they should have been born if there was no manipulation of the sex ratio, but are now not born. And so these estimates vary, but a conservative estimate, for instance, puts it at about 233,000 girls per year that are aborted or are missing because of this imbalance. And then there are even higher numbers which suggest that, for instance, during the 1995 to 2005 decade, each year roughly 480,000 girls were aborted. So these are large numbers, obviously there is a lot of concern both from researchers as well as policymakers on what are the underlying causes for this imbalance. So the sex ratio at birth has not always been this high in India. It started rising in both India and China actually during the early 1980s, and the proximate reason for this was that a new technology, which is ultrasound scanners, became available in the early 80s. Now, we all know that what ultrasounds do is enable you to, in a very cost-effective way and reliable way, to detect whether a mother is pregnant with a boy or a girl. And so having this ability to detect the sex of the fetus early during the pregnancy then allows parents to choose to have a sex-selective abortion, that is, abort a girl relative to a boy if they so want to. And this has happened despite the fact that in India, for instance, sex-selective abortions are illegal, and even using ultrasounds to detect the sex of the fetus is illegal, right? So when you go for an early pregnancy monitoring visit in India, the doctor is not supposed to tell you whether you're going to have a boy or a girl. But since ultrasound itself is not illegal and abortion itself is not illegal, it's very difficult to selectively enforce these laws for specific uses of ultrasounds or abortions. So basically these laws are completely ineffective, and you see that there is a huge increase in the use of this technology. And there's been a lot of here I just quote a few of the headlines that you see from various publications. So Amartya Sen was, for instance, one of the first people who brought this to at least the attention of people in the West about how more than 100 million women were missing. And this number, of course, over the years has been revised in various ways. So just because you have access to the technology does not mean you have to obviously go do a sex-selective abortion. So the technology is simply an enabling factor, but underlying the use of that technology is what is known as son preference. So son preference essentially in this context means that parents really want, or families really want, to have at least one son. And it could be at least two sons, but what researchers have found is that at least in the recent years, what the manifestation of son preference is in terms of having at least one boy. And there are many reasons for this. One, for instance, India is a patrilocal society. What that means is after a couple gets married, they tend to live with the parents of the groom or the husband rather than with the parents of the girl. So if that's the case, then parents really essentially depend on their sons for old age support. And now this is a setting where you don't have social security, right? So there is no social security system administration providing you, old age benefits. So you really have to depend on having a son. And if you don't have a son, then it's really not allowed that, parents should go and live with a daughter, especially a married daughter. So that's one reason. And the other reason is that, the family lineage in patrilineal societies, again, continues through the sons or through the father's lineage. In Hinduism specifically, and this is also true for Confucianism, for instance, that a male heir is very important for, the post-death rites that, parents have to undergo. And this, obviously may seem, not such a big deal, but actually in societies where people are quite religious, then this becomes a very important factor. And lastly, in terms of more economic reasons, it is also the case that daughters tend to be relatively costly than sons, partly because female labor force participation in India is very low. So which means that even if your daughter is educated, her relative income after she starts working is going to be very low, because mostly she's not participating in the labor market. And then the other reason, which is often cited, is the practice of dowry, which is essentially a marriage, a transfer of resources that takes place at marriage from the girl's side to the boy's side. So the bride's family has to make a monetary payment to the groom's side when the daughter gets married, and that, whereas if you have a son who's getting married, you receive this payment, right? So this is the opposite of bride price. And so that's another reason why daughters tend to be relatively costly for parents. So, these are, and there are multiple other reasons that one could talk about, which essentially leads to son preference. So another factor that has been proposed in the literature and that I'm going to talk about is fertility decline. So we are all aware of China's one-child policy, right? So the law basically meant that everybody who has more than one child has to pay a substantial fine. And what we saw that it resulted in is a significant increase in sex-selective abortion. So China's sex ratio at birth went up dramatically as a result. Now there is, controversial controversies in the literature on whether you can really causally pinpoint that these two are related or not. So I'm going to focus on India, where again we see a similar pattern. So India does not have a one-child policy, but what you see in these two graphs is, on the left, you see a huge decrease in the total fertility rate. So total fertility rate is the number of children an average woman will have during her lifetime, and that has gone down dramatically. And on the right-hand side, you see that there has also been a concomitant increase in the sex ratio for 0 to 6 age group, right? So these two seem to have, the same sort of relationship as one expects, with the experience of the one-child policy. So one of my papers tries to look at this in a more of a sort of a causal fashion. And this is a paper that's jointly written with Abhishek Chakravarti and came out a few years ago in GHR. And what we utilize is this legal reform, which essentially imposed fertility limits on local leaders. So these are elected officials at the village level or at the municipal level in India. And it's in various states. So 11 states in India imposed these limits, which basically meant that if you have more than 2 children, then you are not allowed to, or you cannot participate as a candidate in these council elections, right? So it bars people who have more than 2 children from running for office. And, so these are very controversial laws, and the objective, the so-called objective, is that, if we have these laws, then, if your local leaders have lower fertility, that's going to be a role model for the constituents, and therefore they will also have fewer children, and then fertility decrease will then promote economic development, right? This is the older Malthusian sort of approach to population control. And India is actually this is the example of, a first instance, I think, of a democratic country instituting a fertility ceiling for its electoral candidates. And this keeps coming up. So this was for local levels, but in the past several years, people want to institute these limits for state level elections, for national level elections. So this is something which is very policy relevant in the Indian case. So what we do is we examine the effects of these 2-child limits on fertility and sex ratios, not for the candidates per se, but for the constituents where these laws have been enacted. So the way we do it is we utilize the fact that the limits were announced in such a way that if, let's say, when the limit is announced, you already have 2 or more children, then you basically still can run for office, but you should not have any more births, right? So I may have 3 children already, but I can be disqualified if I have a 4th child after the limit is announced. But if I have less than 2 children, then I cannot have more than 2 children, right? So there is basically this cutoff in terms of what your fertility is at the time of the announcement of these laws, and then what you are subsequently allowed to do. Now, of course, if people don't want to run for office themselves, or if they don't care about what their leaders do, then we should see no effects, right? This is just affecting some people who are going to run for office. But we do see that so in the graph on the right hand side, this is sort of an standard event study graph. So we are looking at only the treated states. So these are the states that did enact the law. What we find is that the vertical line is at 0. So this is the year when the laws are announced. What you see is the year before the law is announced, because it takes time to adjust pregnancies. What you see is that there is no sort of trend in the hazard of a 3rd birth before. But what you see very strongly is that there is a significant decrease in the likelihood that people have a 3rd child, right? So this 2-child limit clearly seems to have an impact. And what we find overall, so I'm not going to go into all the details about the empirical strategy and the regressions, all of that is in the paper. But essentially what we find is that for couples who had 2 children when the law was announced, so the limit was really binding for them, we find that the probability of a 3rd birth decreases by 9% for them. And the probability of having a 3 or more children decreases. Sorry, I cannot see my own screen because of all these pictures. Yeah, okay. So the probability of having 3 or more children decreases by 4.4%. And the opposite of this is that, or the counterpart of this is that the probability of having only 2 children increased by 3.4%. So the limits are changing people's fertility choices in the way that it was intended. However, what we see is, again, what is sort of what we see with the one-child policy is that these fertility restrictions then have a negative impact on the sex ratio at birth and increase the number of missing girls. So if your son preference is not changing at the same rate as your fertility is changing, then essentially forcing people to have fewer children leads to greater use of sex selective abortion, because they still want to have those sons, right? So if I have, let's say, 1 child, and now I realize that I can only have 1 additional child because otherwise the limits will kick in, then I will really make sure that that 1 child is a son, right? So, and we see this in the data that the sex ratio of 2nd and higher parity births increases by 10.32%. And this increase is coming specifically from social groups. In this case, it's actually castes, which have historically demonstrated a strong preference for sons. So what we conclude from this is that policies that tend to focus on decreasing fertility for whichever reason can have these unintended consequences for sex ratio at birth, because these two are very closely connected. So then the next question is, so what can we do about it, right? So is there a way to design policies that can sort of overcome what I call this fertility sex ratio trade-off, right? So the fertility sex ratio trade-off is that if son preference is very slow to change, because norms are very slow to change, when you focus on decreasing fertility, the sex ratio is going to become worse. But if you incentivize people to have more daughters, they're still not going to give up their sons. So what you will see is that fertility may go up. Right? So if you are a policy maker that is trying to target both fertility and sex ratio at birth, what can you do? So this is something that a lot of Indian state governments have tried to do, and the most common way in which they try to do this is through financial incentives. So there's a large literature on conditional cash transfers that are used for a variety of things all over the world. And in this case, so this is a paper from AJ Applied from a few years ago, where I examine a conditional cash transfer program called Devi Rupak, which was implemented by one of the North Indian states, which has the worst sex ratio in the country. And they tried to basically improve the sex ratio, but while keeping fertility down. So they had these dual objectives. And the way they did it is that they offered incentives to people who became sterilized after a particular child composition. So if a couple, whether the husband or the wife, has a tubectomy or vasectomy, if they only have one girl, they were eligible to receive $10 per month for a period of 20 years. Now, this is a huge amount of money given the per capita income levels in India. If they only had a boy, but no other children, and they became sterilized, they were offered $4 a month. So this is a lower amount than what was offered for a girl. And so if you only care about financial incentives, then choosing a girl is a much better option than choosing a boy. And then they also had a third option, which allowed people to have two children, but only in the case that they have two girls, you would get $4 per month. So the incentive offered is the same for a boy versus two girls. And both of these incentives are lower than what you would get if you have a girl. So what I do is in the paper, I have a triple difference indifference estimation strategy where I compare women who vary by, whether they're giving birth in the year before the policy came into being versus after, whether they reside in the state which is implementing this policy versus not, and what the number and sex composition of her children was when the policy was enacted, right? So even though there are only three options, it introduces a lot of variation depending on what you are, right? So for instance, if you're childless when the policy started, you have these three options, right? Whereas if you have one girl, then you could choose to stop having children and get $10, or you could have another girl and you would get $4, right? And then so on and so forth for people who have a boy or who have two girls. So what I find is that fertility does decrease, right? So we do see that the number of children overall declines by 1%, but all of this is coming from a decrease in the number of daughters, right? So there's a larger decrease in the number of daughters, but there is no significant effect on the number of sons. And counterintuitively, for the policymaker, what we find is that the likelihood of one boy increases by 5%. So basically, people are picking out of these three options the middle one, right? So even though it gives you a lower amount of money, you have a boy, right? Whereas these two, so clearly between the one boy and two girls, nobody is really going to pick two girls because one, you give up a boy, and secondly, you get the same amount of money, right? So the real comparison would be between having a girl versus a boy. And here what we see is that parents are willing to give up these $6 per month for 20 years as long as they have a boy, right? So what this essentially means is that a subsidy worth 10 months of household income is insufficient for parents to give up sons entirely and have only one daughter, right? So that's giving us some back of the envelope calculation on how much a son is actually worth, so you're willing to give up that much money to still have a son. And interestingly, what we find is that so corresponding to this, we find that the sex ratio of the first child actually becomes worse. So in India, typically you don't see imbalances for the first child because it's not that people don't like girls, it's just that they want a boy, right? So the first child typically is not sex selected, but then if you don't have a son, higher parity births, you see more sex selection. But this policy, since it forces people to choose between one boy or one girl, essentially makes people sex select at first parity. So it's sort of like what the one child policy does in the case of China. But so this, sort of tells you a little bit about how even financial incentives, designed in, so this is, I don't think, a very well-designed program, but if you're not careful about how exactly you're designing these programs, you can actually make the problem worse rather than solve it. And then the second point to conclude would be that just financial incentives may not be enough, because obviously if you give people $1 million, maybe they will not have a boy, but to the extent that that's not a realistic policy, that it's going to be very difficult to design financial incentives to overcome son preference. So another sort of complication that comes in when we think about prenatal sex selection, of course, there are ethical dilemmas, right? Is this morally right or not? But even if we put that aside, another argument that is often made is that prenatal sex selection is simply substituting for postnatal discrimination, right? So sex selection technology is new, right? It came out in the 1980s, but favorable treatment of sons is not new. So before you had ultrasound technologies, what parents did was they still adjusted the sex composition of their children, right? And they did two things. One is you can keep having children till you have your number of sons. This is what is known as a son-biased stopping rule. So what this means is that the last child is significantly more likely to be a boy because people will keep having girls until they have a boy. Or you could deliberately subject girls to neglect. So it was not very uncommon to have, for instance, female infanticide, right? So both of these methods essentially would mean that girls would either be born in much larger families because they have, you typically see a girl, 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 and then a boy, right? So girls will be born in much larger families, and then therefore their outcomes are going to be worse, or you are, going to be subjected to an infanticide. So what ultrasound technology does is that it weakens the reliance on these postnatal approaches of sex selection, right? And what you would then expect is that if you increase access to prenatal sex selection, it may actually result in improved postnatal gender gaps because the girls now are being born are the ones who are more desired or more wanted in some sense. So we explored this question in another recent paper that came out in the EJ, where we look at the effect of ultrasound access on excess girl mortality, gender gaps in health investments, and also fertility. And we again use a triple difference in difference approach, which uses variation in the availability of this technology. So there are different time trends or structural breaks in the availability of this technology, the sex of the first child, because that is often not selected. And also we compare boys and girls. And what we find is exactly, what I was telling, what we sort of expected, that sex selection technology leads to significant improvements in relative survival of girls after birth, right? So before ultrasound became available, the under 5 mortality gap was quite high in favor of boys. And that gap decreased by 60% after the ultrasound technology became available, right? And the mechanism we have in mind is essentially that once you can sex select, parents can align the timing, the number, and the sex of their births to whatever they prefer, right? So if you have the children that you now have are much more desired or preferred, then you invest more in their outcomes. And we also find that this mortality decrease occurs because now girls are more likely to be vaccinated and breastfed relative to boys. And this can explain roughly 26 to 29% of the decrease in mortality we observe. There's also a fertility channel because now if you have son-biased stopping rules, then you typically have very large family sizes, right? Because you keep having children till you have your desired number of sons. But now you can basically avoid having these unwanted births because you can have sex-selective abortions. So you see that the average sibling size is going to go down, and then that can explain another 40 to 50% of the mortality decreases. And consistent with this, we find that undesired fertility, or what is known as excess fertility in the literature, goes down by nearly 74%. So this sort of, creates this trade-off in the sense that, so is it a bad thing if parents are allowed to practice prenatal sex selection versus postnatal sex selection? One way to think of this would be, okay, how many postnatal deaths are you avoiding because of this, and how many sex selective abortions are taking place? So we do this sort of calculation, and what we find is that about 90,200 excess under 5 female deaths were averted each year because of access to this technology. But we also find that the rise in number of aborted girls was substantially higher, right? So it's not a one-for-one trade-off. We find that for every 3 girls that are going missing before birth, only 1 girl survives after birth who otherwise would have died, right? So it is still the case that you are losing more girls than you are gaining because of this other channel. And the other thing that is interesting here is that this shifts the distribution of girls in favor of low SES families, because the girls that are being aborted and the girls that are surviving are changing in terms of which SES they actually take place in, right? So the overall average shift is that now girls are much more likely to be born in lower SES families than higher SES families, because higher SES families are more likely to abort them. And what this means is that in the longer run, we may, as related to what Maya was showing, it could be that, these lower SES families are therefore going to have worse outcomes for girls simply because they are poorer, and then that means that we are going to see gender gaps in adulthood for a different reason, right, relative to what I've been talking about. So then I think I don't know how I'm doing on time. Christina, am I doing okay?
We probably should finish in the next couple of minutes so we have
Sure.
time for a discussion.
Sounds good. So I'll, end by talking about, so I've shown you a few different aspects of this problem, but then the ultimate problem then is, okay, so if sun preference is what underlies all of this, what is the cause for sun preference, even though I gave you some of those cultural factors, and can we do something about it, right? So this is a very difficult problem that people haven't really been able to solve. But what essentially the literature talks about two things. So if this is a very deep taste for suns, then it's very difficult to change these cultural norms in the short run through these financial incentive programs, right? On the other hand, if it is driven mainly because sons are more valuable, either because of dowry or because of their ability to earn or provide old age support, then maybe public policy can change this behavior through, let's say, for instance, instituting old age social security, right? Then people's dependence on sons goes down. So in a related paper, we do this in a roundabout way. And what we look at is one of the most important structural changes that took place in India which is the 1995 tariff reform, right? So this was the trade liberalization that took place in India. And what we find is that it affected relative female income. And what we find is that that in turn affects fertility and sex ratios. So for groups which experienced a rise in relative female employment and therefore income, we see that they're significantly less likely to do sex selective abortions. Whereas in groups where the relative female employment was in the other direction, we see that sex selective abortion goes up, right? So this clearly tells us that if the economic value of women goes up, parents are less likely to then have sex selective abortions. And therefore, this tells us that maybe there is some sort of economic motive for sun preference, which we can try to address through public policy. One caveat of this is that we also find fertility goes up, but that's that's sort of coming back to the fertility sex ratio trade-off. So I will wrap up now. Essentially, what there's a lot of debate and concern in India about imbalanced sex ratios, and that's because there's a large literature which has shown that they can have negative consequences for the marriage market, for old age support, and even crime. And the complications that result from sex selective abortions can also lead to significant maternal mortality, especially because many of these abortions are taking place in illegal hospitals or health providers. So what my research suggests that sun preference does seem to have some economic roots, but the net benefit to parents from a son is so large that it is very difficult for short-term policies or financial incentive programs to overcome it completely, especially if they want people to give up having a son entirely. So there's ongoing work that I have on trying to understand how sun preference has evolved over time and what are the general ways in which gender norms can be reshaped. So I'll stop here. Thank you.
Thank you so much to both of our presenters today. Thank you, Maya, and thank you, Anu, for your time in these fantastic presentations. I'm going to turn it over to Danny Sandler, the SGE Vice President, to kick us off on the Q&A section of our session today.
Yep. So just want to invite people, if you feel free, we can have people jump in and to ask questions out loud, but you can also, if you would like to ask a question and can't ask it yourself, feel free to put it in the chat and I can look at the chat and convey the questions to our speakers. I'll kick us off with a question to Maya. So there's been a paper that's been doing the rounds the last day or two on that blames the entire rise in maternal mortality on that change in the pregnancy checkbox. I was wondering if in your data you see rise in maternal mortality over time, if you ended up looking at that.
Thanks, Danny. Yeah, we saw that paper very recently, and we were immediately like, oh my gosh, can we do something in our data to say something about this debate for those of you that are unfamiliar? So one of the challenges with the fact that the CDC measures maternal mortality with this pregnancy checkbox, which is meant basically a checkbox on the death certificate that is meant to signify that the deceased individual was pregnant within 42 days of the, within either 42 days or a year of the death, is how it's defined. And the CDC came out with a new report on maternal mortality that, you know, stated that maternal mortality rate rose tremendously in these last few years. But they've also said that you shouldn't compare like maternal mortality rate, you know, today with maternal mortality rates in like 2006 because of changes in how they've been coding it, making it really hard to say something about trends. And then another paper came out that basically argued that essentially the sort of increase in maternal mortality rate has been overstated because of these coding issues. So we're actively trying to say something about that with our data. What I can share right now with, you know, census disclosure rules heavily in mind, I'm not going to share any numbers, but what I can say is we can essentially measure maternal mortality in the numinant data, as well as using sort of the standard way with death certificates right now. And so we can do it for the entire country. We can do it for just the state of California, where we have the birth records linked to the numinant. Our sense right now is that the trend definitely has been increasing nationally. The thing about California is that that's one of the states that, even according to no matter what measure you use, maternal mortality rate has been going down here. So California is actually an outlier. So it's a little tricky to do all of this in the context of California, but to the extent that we can make the case that you know, we can do similar things nationally and for California with one of our data sets, we might be able to say something nationally as well. And at least for now, it seems like there's definitely been an increase, but the precise magnitude of that is something that's still under analysis.
All right. And a question for you, Anu. So you talked about how prevalent the sun preference is in India. Is there evidence on other countries? I thought at some point I heard that there's actually a daughter preference in some Western countries. So do you know anything about how things shift over time in other places?
So yeah, so I think there's some papers that try to look at this. So there's definitely evidence of sun preference in Asian immigrants in the US and the UK, for instance. So Doug Armand and co-authors Lynn Edlund, they have looked at this in the US, and they find that even US, Canada, as well as the UK, that Asian immigrants tend to have this preference. And this is, they observe it for the first generation, I think, but that by second generation, I think it sort of goes down. But there is still persistence in the beginning. There is also a lot of recent evidence of this from Vietnam and the Caucasus. You know, so the Caucasus have a very high sex ratio at birth, and I think you know, again, there's very little research on why that is the case. You know, so places like Georgia, Azerbaijan, you know, you see a lot of that. And I think in sub-Saharan Africa, I was recently looking at this. So, you know, the paper I cited about how many excess girl deaths you have per year, they actually estimated for, you know, the global data, and they find that sub-Saharan Africa also actually exhibits a lot of this excess mortality at birth, even though we don't associate it with actual use of sex-selective abortions. So, you know, so I think it varies in a lot of places. In the US, I think there was this other very nice paper from long ago, I think it was Dahl and Moretti, which finds that shotgun marriages, for instance, are much more likely to take place if a woman has a son, right? So even though there was a preference for a mixed, actually there's a preference for mixed composition, what they found is in cases where a woman gets pregnant and you know, they're not married, if she has a son, they're much more likely to get married than, you know, so it's difficult to know. I think Seema Jayachandran has looked at this using historical census data. And she doesn't find, because in that far back in time, you obviously didn't have ultrasound technology. So she looks at the last child's sex ratio, and she doesn't find it to be imbalanced. But we don't actually have a lot of credible work on trying to look at it historically. Yeah.
Looks like we have a couple questions for you in the chat. So do other Indian states have policies similar to the ones you've analyzed?
So yes, definitely. So the one that I analyze is one of the first ones. And since then, a lot of other states have tried to do this, and they've all tweaked in different ways. So the amounts are slightly different. Some, for instance, only give it, the incentive for one boy and one girl, and not for two girls, so they're trying. I think there are other people who have tried to analyze them, and broadly, they don't find that much actually. They don't correct the sex ratio, since that's what they're really after. So, but a lot of Indian states have similar policies. And then I think the second question is, why do you think India made the male child subsidy into girl subsidy? I don't know. I have no clue how much thought and analysis actually goes into the design of these programs and the exact amount. So I really wouldn't be able to say, why they came up with these numbers. Yeah.
So opening the floor to other questions, either in the chat or you're feel free to unmute and ask.
Hi, I have a question to Maya regarding your research. So in your data set, were you able to identify the birth using the assisted reproductive technology and the natural birth?
Yeah, so the birth certificates data, at least in the recent years, but since 2007 at least, have a variable basically that says if the pregnancy was conceived with the help of ART. It doesn't provide further details, so we don't know if it's IVF or IUI or another type of treatment, but we do know sort of ART. I believe in terms of where that data comes from, I believe it's self-reported. So it's the mother, when filling out sort of the birth certificate information, has the option to check this box. So it's probably not perfect, and perhaps not as accurate as if we had it through like the insurance claims or something like that. But that being said, in the US, actually, ART is not always covered by insurance, right? So, this is probably the best that we can get.
Yeah, so I was curious. I think you've mentioned something about like singleton births versus the plotters. I think that's the driving force why the like higher income births have the lower like worse birth outcomes. But when you looked at the natural birth only, there's the trend toward both in terms of low birth weight and the infant mortality rate.
Yeah, so when you restrict, so we should have done this. We actually haven't looked at non-ART only. And what we have done is we've looked at singleton only, which, to a first order approximation, like a lot of this is about the non-singleton versus singleton and the sort of the way that ART substantially increases the likelihood of that. But if you do it just for singletons, like basically you no longer see the J in low birth weight, it kind of flattens out, so it's not, it's not a perfectly monotonic decreasing motion, but sort of like kind of flattens out like a hockey stick, I guess. But you still see the same gradient in infant mortality. And so sort of for the highest income families, mortality rates are just substantially lower than they are for the lowest income families, no matter how we cut the data. But yes, the pattern, sort of the disproportionate rate of preterm and low birth weight is quite a bit muted when you just look at single.
Thank you. Great research.
Thank you.
Hey, Rachel, you
you're
seem to be
unmuted.
muted. Oh, have you untype it, Rachel? I can ask for you if your mute isn't working. I can also try to unmute you myself. Yep, we can still see you, but not hear you. I'm sorry, Rachel. We heard you earlier.
I see the chat now from Rachel.
Okay.
I'm happy to take a stab at this. So let me say two things. So one is that so you're completely correct that our data is such that we can only measure live births. And so to the extent that there's anything going on in terms of either fetal deaths, miscarriages, or other types of terminations, including abortions, we're not directly able to measure that. That being said, I think in terms of like the extent to which that is a mechanism for anything that we're observing in the data on live births, we think that's unlikely just due to the sort of the magnitude of the differences that we're observing, that it's unlikely to be driven by sort of like differential composition selection into who's born. And then we've done some back of the envelope calculations along those lines. But I think a more important issue is the extent to which, differential access to reproductive health care, that's obviously become even more of a big issue in the last couple of years following the Dobbs decision, may either contribute to or exacerbate the disparities that we're finding. So again, I can't say too much about this in the context of this specific project. Moreover, I think as far as states go and access to reproductive health care, California kind of is pretty good on that dimension in terms of having good access. But I think that's still an important question to continue to study. I have another project where we're using Medicaid data to try to study the effects of access to reproductive healthcare, in particular facilities, abortion facilities, on women's mental and physical health outcomes and pregnancy complications, things like that. So stay tuned. We're hoping to release a paper sometime soon, maybe, with what we learn. And from that, in terms of access to prenatal testing, so I think for sure, like as far as like resources go, especially the sort of extra tests that may not be covered by insurance, probably there's some disparities in terms of access there. I will say that California has like a pretty robust statewide program on kind of the key prenatal tests that is free and available to everybody, and like kind of so as long as you're attending regular prenatal care, it would be done. So I think at least in the state of California, that difference in access to prenatal testing is probably more muted than it might be in other places.
All right. Well, I think we are close to the end of our session. So if there's no other questions, I'm gonna hand back over to Christina or Mel to close us out.
Well, I want to
Awesome.
thank both panelists. It was a very enjoyable session. I think Christina might have some more words.
Thank you so much, Mel. Thank you, Danny, and thank you to both of our speakers, Maya and Anu, for your time today and for filling us in on what's going on in the world of maternal and infant health inequalities. And I'd like to thank everyone for participating and for attending today. I think we had a great session, so thank you so much. And stay tuned for upcoming seminars. We'd love to have you back. Have a great
Thank you
day,
so much.
everyone.
Thanks for having us. Bye-bye.
Bye.
Christina, should I write